I'm Tayyibah Dhorat. As Dr. Bailey Stanton mentioned, I am a community service medical officer. Currently at Rahima, I completed 6 months in the ED, which I thoroughly enjoyed, and I'm now doing 6 months in pediatrics. Today I'm going to be speaking about non-accidental injury, which is commonly known as child abuse. So I'm going to jump right in. So that is what our topic is about today. In terms of the definition, non-accidental injury refers to injuries with a suspicious mechanism. For example, spiral fractures in non-ambulatory infants, bruises in non-mobile children, posterior rib fractures, head injury without external trauma. So it suggests abuse, but needs further assessment to confirm child abuse. In terms of the epidemiology, from recent official reports in 2024 and 2025, 26,000 cases of child abuse or neglect were reported to this Department of Social Development, and they've broken it down into about 10,000 that were sexual abuse, 10,000 which were about neglect, and about 4,000 which were physical abuse. And these were just the ones that were reported. We don't even know about the ones that weren't reported. So what are some of the risk factors for non-accidental injury? Poverty, social issues, parental illness, substance abuse, cultural acceptance of corporal punishment, domestic violence, young or single parents, children under the age of 2 years, and prematurity or disability. And all of these risk factors we see quite commonly in our setting. So how do these kids present? They will have a vague and changing and inconsistent history, injuries in a non-mobile child, delayed presentation, and multiple injuries at different stages of healing, which is exactly what we saw in our kiddie. So when it comes to the physical examination, as always, we start with our primary survey. On A, for airway, we assess our airway patency. We assess for any facial injuries, any signs of smothering or strangulation. And if you are concerned for C-spine instability, we will immobilize the C-spine. We assess the respiratory effort. We look for chest wall injuries. I mean, these kids can have any kind of, it can extend to anything. So they can have rib fractures, burns, bruises. They may have pneumothoraces. Diminished air entry may suggest pulmonary contusions. Under circulation, we assess their perfusion with paying special attention to their heart rate, their cap refill, BP, pulses. We inspect for bruises, bleeding petechiae. And then we assess their consciousness. We do an FPU or GCS score on them, assess their pupil size and reactivity, check for seizures, altered tone, and signs of raised ICP. So under the physical examination, we want to fully undress them, head to toe, and document findings precisely. If you need to take photographs, you can do so. Burns, they usually occur in a glove and stocking distribution in the lower limbs, and there will be absence of splash marks. And then you get specific kind of burns, which will have specific kinds of patterns, which I'll show some pictures of, cigarette burns, iron burns, etc. You may find bite marks, belt marks, loop marks, and then fractures. Again, the injury won't be necessarily compatible with the history given. There will be recurrent incidents, injuries of different ages, which I've mentioned before, and unusual fracture locations, such as rib fractures and skull fractures, as well as bruises, unusual sites of the bruise, and patterned bruises. So these are some examples of the specific patterned bruises that you can get. On the top left, we have open hand slap marks. There you have this parallel linear bruises, belt buckle imprints, tramline bruises, and fingertip or grab marks. You can see on that picture there. Don't forget to plot the growth parameters, because these kids, such as our kid, they have a lot of associated developmental and nutritional issues as well. A lot of them are malnourished. So plot the growth parameters do a developmental assessment and nutritional assessment, and do not forget to do a genital examination. Sexual abuse is another entire topic on its own, but it's very important to exclude it at this point. So under your investigations, we were always taught to do the most simple, bedside, cheapest investigations first. So we can start off with a urine dipstick. Urine dipsticks may give indications of associated renal injury or sexual abuse. Pregnancy test in an older child, VBG, it can also point towards hypoxia, acidosis, metabolic derangements, etc. You want to do a focus, which we love in our ED. We can do an EFAST to detect any free fluids. We can even do a retinal examination on the ultrasound to rule out any retinal detachment. And then in terms of bloods, we can do FBC, ESR, CRP, CMP, clotting profile. So all of this depends on where your mind is going, and in terms of a differential diagnosis. If you want to rule in or rule out certain metabolic causes, if you've seen lots of bruisings and you're not really suspicious of a child abuse kind of situation, then you would do these tests and accordingly treat the patient. So UNE, creatine kinase, if you are thinking of a crush injury, LFT, tox screen where applicable. In terms of imaging, as I've mentioned with our kitty, we did a skeletal survey, which basically takes an X-ray of all of the bones in the body, especially the long bones. And you can do a CT or MRI to detect things like subdural hematomas, as well as cerebral edema and intracranial bleeds. So in terms of our management, we'll stabilize the child according to the way they have presented and according to our algorithm. Always do not forget to give these kiddies analgesia. Exclude medical disorders, especially your bleeding disorders, things such as osteogenesis imperfecta, rickets. Some traditional practices have the practice of making little scars on kids. That is not child abuse. So it's also important to keep that in mind. And as I've mentioned before, make detailed notes, diagrams if necessary, J88 and a Form 22. So this is for reporting of abuse and deliberate neglect. Refer to social worker and assess child safety. If you need to separate the child from the mom and you need to take such measures, then please do so. So it is a multidisciplinary approach. After, it does not just end in the ED. So we are there for initiating the process and identifying red flags, but we are also responsible for initiating referrals and keeping the child safe. Pediatrics will be involved for any associated medical issues, neurosurgery if necessary. We can consult psychology to assess for trauma, PTSD, anxiety, depression, provide play therapy to these kiddies, trauma counseling, etc. Social worker to assess the home safety and environment, coordinate temporary or long-term placement, dietitian, physio, OT, ophthalmology if there's associated retinal hemorrhages that we would see in shaken baby syndrome. And I would like to end off with the Children's Act 38 of 2005. It applies to all children under the age of 18. And Section 110 says you must report suspected child abuse, neglect, or exploitation to a designated child protection organization or the Department of Social Development. Failure to report is a criminal offense. So the key take home is think NAI in any unexplained injury, and ED is often the first and only chance to identify and intervene with these patients. Thank you.